Okay. Good evening, participants. I welcome you all for this DNB Anesthesia RAISA academic online activities. Today we have with us Dr. Samir Basak, DMO from Garden Reach Hospital, Southeastern Railway, to present this very important topic on essential pain management. It will be very useful for continuous pain medicine practice in your career as well as clearing your exams. So I introduce Dr. Samir Basak. Is very active and enthusiastic pain practitioner, and he is well known in the field of pain medicine all over India, and is a gold medalist in Indian Society for Study of Pain Management, Pain Medicine. And I hand over the session to Dr. Samir Basak. Over to Dr. Samir Basak.
Thank you, sir. Good evening, all the delegates and respected doctors. My topic is essential pain management. And previously, I have taken on one class, that is the how we go through the syllabus of the pain medicine as a anesthesiologist doctor. And we have seen that in anesthesiology, to pass or to become an anesthesiologist, there are huge interest. We should have huge interest in the field of pain medicine also, because the pain medicine is a sub branch, and almost second and third paper and part of fourth paper also contain lots of question on the from the field of pain medicine. And right now this topic I have chosen as a second day of our pain discussion CME. And this topic is must for a as a doctor, as a healthcare provider. I say it is a topic must for the healthcare provider also. So what is it and how it is introduced? It is introduced by the Society of Australia and New Zealand anesthesiology doctor and fellow of the pain medicine. So they have introduced the concept of essential pain management, because in our day-to-day life we see patient presenting with the pain. There is varieties of pain, and we can't understand what type of pain it is, and we prescribe rampantly any of the medicine what we can remember, what we can like paracetamol, tramadol, we can prescribe any of them. But we should use pain medicine as a judiciously, so that it should be effective for the patient and reduce the harm. So this topic is initially only offline, but now it is online, content is available. It takes 2.5 hours to go through the topic and followed by one exam. It is the essential pain management, and if any doctor pass it, they will get certificate from the AJNK board. So this is the access of the course. This is the, available in the praxap.com. You can scan this QR code. I am slowing my presentation here. You can scan this QR code to go directly to the praxap.com, and from this you have to search as a EPM, and you will get the full details of the course. And it is widely available after the month of January all over the world, and anybody can do this course. Any doctor, any paramedical person can do this course. Okay, so this is the EPM online course. I am just going through the content what is available on the online. It is the rat, like rat is very fast, rat animal is very fast. So we should be very fast in assessing the patient, in managing the patient. We first recognize the patient, then assess, and then treat the patient. Who is presenting with the pain, any type of pain condition, we should go as a rat protocol: recognize, assess, and treat. So regarding the recognition, how to recognize the pain? As per ISP definition, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It is the definition of the pain. There are some keynote. Pain is always a personal experience. That is what we feel at varying degree. That may be biological influence, there may be psychological influence, or social influence is there. So what patient experience, this is the pain. and we should respect it. We should not assume that it is psychological fully, there is no pain. And like this way, there is a biopsychological model. There are some belief of ourselves, there are some attitude of expectation, some emotional content is there, some memory, all this is psychological part. And there are social support, some family person suffering with cancer, there are some social stigmas like culture belief is there. Then come the neurobiology, immune system, and the genetics, all the biological. So pain and ultimate feelings, ultimate verbal expression, pain is a part of the biopsychosocial model of our system. From all the content available in the PACSUB, so do you think this small child is in pain? Actual answer is this child is demanding candy. When she not getting this candy, she is crying. So she is not in pain. Also, this lady is in pain or not. She is thinking in front of laptop and she is stressed with her work. So also in this condition, she is not in pain condition. This is a stress or other type of psychological effect. This there. The smiling face of mother with the baby. This mother is laughing right after the delivery. Uh, so she is in pain, but her smiling face demonstrate that there is no pain is there. So we cannot only look at the patient and assume she is in pain or not. We should ask them. So how we recognize? We should best way to ask them. Hello, Mr. Hello, Mrs. Are you in pain or not? So this is recognition. Best way to is to ask the patient. There in biopsychosocial model, sometimes it is hidden. Facial expression will not demonstrate the patient is in pain or not. So why should we treat the patient? Because it is good for the person, for the family, and for the society. For this reason, we should treat the patient. And for the patient, their body return to the normal, their blood pressure, their sleep will be normal. This is for the patient. And for the family, this will be less worried about the problem. They will be decrease the stress. All this leads to less problem. Right now, for the society also, will return to the community faster and shorter hospital stay, reduce the healthcare cost. For all this reason, for the benefit of the patient, for the benefit of the society, for the family, for all reason, we should treat the pain as a humanitarian ground. So we will go through 4 cases, and these 4 cases we will discuss throughout the discussion. And this first case is, why should we treat this old lady's pain? She is in cancer and her name is, for the online, it is Maria, 44-year-old cancer patient living in a large city. She is married, four children, 11-year, another is 8-year. She is in advanced uterine cervical cancer. Cancer spread towards spine and pelvis. She had maximum treatment for his cancer. Now she complained of new low back pain and also left leg and pelvic pain. So case 1 for 44-year-old cancer patient. We should treat her pain as a ethical humanitarian ground to reduce her suffering, will reduce her anxiety, will improve her sleep and appetite, and it will reduce the family stress for husband, for the children. Case 2 is old male after post-op period. Why should we treat his pain? His name is Daniel, 74-year-old post-operative patient, undergone laparotomy for bowel obstruction, and as a doctor you are seeing in surgical ward soon after the operation, and he complaining of severe pain. Case number 2. we should treat also his pain because of ethical ground, increase the comfort, reduce the heart rate, blood pressure, improve his ability to sit up, to take deep breath, improve chest compliance followed by infection, improve our mobility. So this is the case number 2. And case number 3, this young boy undergone operation for 7-year-old Tommy, post-op patient, just laparotomy for perforated appendix, which caused peritonitis. This is the third case. We should treat his pain because ethical humanitarian ground, to improve the comfort, to reduce the fear and stress, to improve his ability to sit up, to give peace of mind for the parents and the family. And case number 4 is just this last case. This is the one patient, old patient with amputation, John, 50-year-old amputation patient who had below knee amputation following motor vehicle accident 1 year ago. He comes to your clinic complaining of pain in the absent foot. So missing part, there is pain. We should treat as a humanitarian ethical ground to improve the comfort, to improve his sleep, improve his mood, return to some type of work for a good family, for good society outcome. So we should treat this patient this way. And now we should assess how much pain, what type of pain, what are the other factors. Regarding the RAT protocol, we should go assessment part. How we assess these 4 patients? We are taking these 4 patients only right now. There is a visual analog scale 0 to 10. 0 means no pain, 10 means worst pain, and 0 to 10 there is 11 point. You can put the chart in front of the patient and patient will demonstrate it. If child, if any other type improper patient verbally, then we use faces pain scale. Faces, there is 6 faces, smiling faces. From the smiling face is there to worst crying face. This is the faces 5th and 6th. It will demonstrate the maximum possible pain condition. Wong-Baker faces scale 0 to 10. Wong-Baker faces also demonstrate similar way. The heart's worst and no heart. So we should ask few questions. This is the 3 question. How long you have pain? That is acute or chronic. What is the cause of the pain, like cancer or non-cancer, and what is the pain mechanism? How does information go to the brain? So these 3 questions we have to ask, and we have to ask few questions to the directly patient, and we have to assess by examining the patient. Regarding the duration, acute pain is a pain of recent onset, or chronic pain is more than 3 months, or pain lasts more than normal healing time. It is the chronic pain. The cause important to recognize during the assessment, it is from cancer or non-cancer. It will by we can clinically, from radiological, from investigation we can assess this is a cancer or non-cancer. And if there is cancer, there chance of mixed pain like acute or chronic mix is there. Then comes to the mechanism of the pain. It also guide us the treatment protocol. Regarding the mechanism, there is nociceptive, neuropathic, and last is nociplastic pain. So the nociceptive and non-nociceptive, regarding this, nociceptive is there is tissue injury, and obvious tissue injury is there. Pain has the protective function. It is localized, may be described as sharp and or dull pain. This is nociceptive pain. There is some problem, some infection or some activities going on, appendicitis, something is there stretching the visceral structure, labor pain, there are some toothache, arthritis, joint in degenerative inflammatory changes, or degenerative changes leads to some joint changes, or leads to uh, activation of the nociceptive stimulus. All this leads to fracture, all this leads to nociceptive pain. Whereas non-nociceptive is there is it has no protective function. Tissue injury is not there, and it is classified either peripheral or central non-nociceptive pain. Neuropathic component or nociplastic component is there. How we will assess? There is nerve injury. Obvious nerve injury is there. This is the neuropathic component. Nerve compression, like there is the median nerve compression due to thickening of the fascia, it leads to carpal tunnel syndrome. The peripheral neuropathy due to diabetes, peripheral nerve got damaged, long-standing diabetes, or there is cancer leads to fracture of the vertebra, there is central pain, or there is stroke component is there, brain damage. So all this leads to neuropathic pain. There is some nerve damage is there, and it is chronic, it leads to nerve mediated neuropathic pain. Whereas nociplastic, like a low back pain, there is no injury, no apparent injury is there, but still pain continue for the more than 3 months, and it is no protective function. This type of condition, there is nociplastic. This is the altered nociception without clear lesion of the nervous system. Chronic low back pain, chronic pain, neck pain. There is abnormal processing and sensitization of the nervous system. It is usually not well localized. It is the nociplastic pain. So there are other factor like social factor, biological, psychological factor is there regarding the how he will experience or feels the pain. So in this picture, we can see there are lots of pain eliciting structure is there. There are the pin is there, but he does not complaining of pain. This is the modulation, pain mechanism modulation by inhibiting by system, descending opioid system is there. So by modulating our pain mechanism, he is not complaining of any pain. So these are the important our belief, our mood, our cultural factor. There are some spiritual component also there in the previous picture. Our past experience, social factor, all this leads to our final verbal expression of the pain. So we have to be judge all the things to assess as a part of the final expression of the overall pain perception. There are many factors how will fail pain, psychological, social, and as we told previously. So different treatment option is there uh, for different pain mechanism abnormality, like peripheral is injury, for we have to be use some medication. Problem is the pain carrying fiber ascending pathway descending system, then we have to use other medication. So the four essential component, as we told in the first class, there is the peripheral, spinal cord, brain, and modulation is there ultimately. All this leads to pain perception is there. So non-nociceptive pain physiology, there is the as we told diabetic neuropathy, HIV neuropathy, nerve damage. So we have to be clinical examination is there for neuropathic pain, like the pain aid scale, like other chronic neuropathic pain component we can assess. There is other scale is there. With all these parameter we can assess the pain is a neuropathic pain component present or not. Regarding the assessing of the pain, in the case 1, who is the old lady presenting with the cancer, how we assess this patient? We should, regarding when we assess, she demonstrate that moderately severe pain, 5 out of 10 for last 8 weeks, with no pain prior to that. She demonstrate tingling, needling down sensation is there, and also sharp aching pain is there. So both component is there, neuropathic and nociceptive, in the lower abdomen and the middle of her back. So her pain worse, get worse, he try to walk or go to the bathroom. So pain increase during movement. She is a cancer, worried about how they're also worried about how long she is to live. So psychological component also there. Regarding the treatment also, we have to focus on all this part, like psychological part also. Then in the assessment, we have found that this is moderate, acute, cancer, mixed nociceptive and non-nociceptive neuropathic pain is there. Neuropathic pain score, when we assess, it will also demonstrate few score also there. Regarding the assessment of this old man who had undergone surgery immediately post-op period, this also demonstrate that pain in the rest period 5 out of 10. This is moderate, and 8 out of 10 when trying to sit up or cough. So during any movement, pain is severe. So his pain is severe right now, not moderate, is severe. This is one second condition. This is severe acute non-cancer nociceptive component immediately post-operative period. And this young boy undergone operation for perforated appendix. He is awake, tummy is pain when try to turn side, and his faces pain rating point to the faces spine 5, that is equivalent to NRS score 10, 8 out of 10. So he is also severe acute non-cancer nociceptive pain condition. And last case, this is amputation 1 year back accident. Right now he described pain as a fourth phase, and pain 6 out of 10 is the elective shock life in the absent leg, and the foot sometimes feels foot is on fire. So it is neuropathic component is there, and it is worse at night. So John was a road worker. No longer do the work. He is married and 2 children, adult children who can help. So he has also some family issue, some psychological issue is there. We have to look also psychological component while treating the pain. So this is moderate, chronic, non-cancer related to non-neuropathic, non-nociceptive, that is neuropathic pain is there. Neuropathic component is mostly here. So after we recognize and assess the patient, we have to go for RAT treatment protocol. This is the non-pharmacological and pharmacological treatment. What are the non-pharmacological options? These are the physical, and physical option depends upon the type of the pain, like rise, rest, ice, compression or elevation in acute condition within 72 hours. Next come the acupuncture, TENS, massage, hot and cold pack, movement, surgery and physiotherapy. So rice is a first aid treatment, resting the painful area, applying the ice or cold over the affected area, compression of the painful area and elevation of the area above the heart level. These are the rice protocol for acute pain within 72-hour injury. After that, this is a traditional Chinese system acupuncture. It is useful, may be useful for acute pain or low back pain, neck pain. It is useful chronic condition also. TENS, usually physiotherapists do it. It is the our pain system is regulated by the larger fiber A beta. That is the electrical nerve stimulation, which electric impulse adjusted our sensory stimuli. So it is modulate our pain. This is the TENS, transcutaneous electric nerve stimulation. And now comes the manual practice therapy, like the massaging or moving the applying part, muscle, tendon, ligament. Next come the applying the high ice pack for the acute inflammatory or the hot pack for the muscle stiffness or pain, using hot and cold pack, and surgery like inflamed appendix or similar type of condition, removing the affected part or fixing the part. Next come the physiotherapy, targeted education, guided active patient care or the manual therapy. So these are all non-medical, non-pharmacological treatment. So we have to educate, reassure and try to respond the active role in the teaching them. They have also saved an active role in self-management, relaxation, meditation or problem solving. The patient have active role in their managing the pain. Next come the this is the part reassurance, like cognitive behavior therapy or some other therapies there. and this is a self-management, tai chi, meditation, teaching how to respond with the pain, chronic pain. It is mostly helpful. So now come the pharmacological therapy. It is divided in the three groups: simple analgesic and strong analgesic like opioids, and co-analgesic or other analgesic like not analgesic directly and not anti-neuropathic medications. So WHO treating ladder for cancer pain, it is for helping for the mainly acute pain or cancer pain. It is not helpful for treating the chronic pain. When there is acute pain, we should start from the severe step 1, step 3, then step down gradually. We should add other medication when this is required. In cancer patient, as there is the other neuropathic component is there. So we should step up or step down the pain ladder as required. This is a reverse step ladder after the post-operative period of trauma, as we told earlier. Immediately strong opioid, then mild, then paracetamol or other medication. Reverse WHO ladder. And the medication, there are some indication for the medication, which medication should use in which condition. Paracetamol is safe, but disadvantage is liver damage in overdose. Other NSAID, chance of gastric and renal side effect is there, we should keep in mind. Mild opioid, there is chance of nausea, vomiting, and strong opioid, chance of respiratory depression. And in high dose pethidine also, only injection form is available, oral form is not there. We should keep in mind this. So anti-neuropathic medication like amitriptyline, gabapentin is there. Also local anesthetic is there, and also ketamine and nitrous oxide also is there. Other co-analgesic. We should go for multimodal treatment for acute pain, and different analgesic by different route should be applied. What medication and what system? Like at the periphery, if you understand this slide, this will be very easy for you to treat any pain related condition. Like there is injury, like there is toxic stimuli, like injury is there, we should use anti-inflammatory medication like steroidal or non-steroidal anti-inflammatory medication, or we can use local anesthetic. So these are act on the periphery. This is one important slide. And next is when there is involvement of the pain carrying structure like spinal cord, there is we want to treat at this level spinal cord, sorry. So we should go for opioid, local anesthetic or ketamine. At this level, it is very much useful. And non-pharmacological acupuncture or massage at the level of spinal cord. And when we target the brain, paracetamol, opioid, or other co-analgesic are there. Opioid, paracetamol, tramadol act mainly on the brain. So when we use some opioid for acute injury, they act on spinal cord. When you use some NSAID for acute postoperative phase, they use at the injury or inflamed or cutting site. So these are the main target area. We should use our medication by looking at the structure involved and what is the problem going on. Right now, sometimes we use no medication. This is called the placebo effect. This is a therapeutic effect from an inert treatment, but that does not mean the patient is not on pain or pain is not real. Uh, it is also a cause release of endogenous opioid. For this reason, placebo effect act. It increase the descending modulation. So this treatment also effective, but it is short lasting placebo effect. So this does not mean that patient telling lie. Huh? So placebo effect, it is a short term, short lasting. Their effect is there. When we think about the opioid, regarding the opioid use in India, only 4% we use the opioid. Rest, if you look at the US and Canada, they use 30% or around 31% use overall, all over all the available opioid. So opioid addiction problem is in this developed country. not in our in India, developing country, opioid addiction problem is not much common. There are three signs regarding the opioid addiction: craving, loss of control, and the negative consequence regarding the opioid addiction. All this, what I am telling, available in the online course is there. So, regarding the counter opioid misinformation, we have to assess the risk before the pre-exposure psychological factor. Patient is in trauma or not mental. We have to assess this before prescribing an opioid. There are some form before prescribing opioid. We have to fill up this form. So regarding the case 1, Maria, 44-year-old cancer patient, when we assess her pain as a moderate cancer, acute, mixed nociceptive neuropathic, no, both component is there. How we treat her? So treatment comes with the non-pharmacological. We have to listen her fear, her hopes, what he is thinking. Then trial of warm pack at the back and the leg, the massage, and the mindful and relaxation therapy, positioning. All these are important factor. This should not be neglected. Only medication is not only helpful. Right now, then we severe component is there. So we use oral stronger opioid like morphine. Then short acting morphine, we have to go for regularly slow release morphine, twice daily dose. Also we add paracetamol, low dose steroid, NSAID, or low dose co-analgesic like gabapentin, amitriptyline, because mixed component is there. This is the cancer mixed nociceptive neuropathic pain component. We have used all the component and target all the component. Right now, post-op patient, 74-year patient, severe acute non-cancer pain. Uh, we have to also target non-pharmacological, like we have to explain what are our plan to relieve his pain, instruction about the exercise, deep breathing, or getting assistance during the bed, getting out of bed, and the physiotherapy to calf improvement. Physiotherapy is important. Social support. This with this comes to the IV morphine initial period for 24 hours, after that convert to oral morphine. And when we prescribe morphine, we have to use stool softener, regular paracetamol, and low dose NSAID, because there are the tissue cutting inflammation is going on. So we have to use NSAID. And this patient, Tommy, 7-year-old patient, after post-op period, we also reassure him non-pharmacologically, distraction method by watching a TV program, by favorite toy, encourage slow breathing, and physiotherapy. Just physiotherapy also is important. So with this, we go for opioid or non-opioid like paracetamol or morphine. If within 24-hour opioid is if required, we should give without hesitation as the required dose. Then go for the case 4. This is the old amputation patient, moderate chronic non-cancer pain, non-nociceptive pain. We use non-pharmacological method, explain the simple to understand at what language he understand, reassure him, and option to allow mobility device prosthesis, explore the type of lesser type of work he can explore, so that his mind will be distracted, and amitriptyline or pregabalin trial should be prescribed. So after that, we have to reassess the patient. In case of acute, within 30 minutes to 1 hour. In case of chronic, after couples of week to month, after 2 weeks or 3 weeks. So after initial assessment, when we see the pain severity score, record, VAS scale, neuropathic pain scale, then we assess, and we adjust the medicine dose and titrate the dose accordingly. So when we treat one patient, there are so many barriers for the treatment, like the patient factor, like the medication, health worker, and the system issue. All this leads to improper treatment, and pain is not subside. What are the main barrier? Like healthcare, therefore no guideline about the knowledge about the patient. Sometimes the lack of referral system for pain management. So patient factor, patient expectation something, and we treat something way, some other way. There are some social belief, some patient knowledge, and patient is in village, they are not accessible to modern treatment. All are there factor. uh, so when there is some two cases also there in the online. This first one is acute burn patient, right arm burn in emergency hospital and emergency department. Let's follow the medical staff, recognize, assess and treatment. What will be the treatment protocol? This one you should do by yourself. And another is chronic non-cancer pain, 50-year-old lady, long-lasting low back pain. There is no clear anatomical pathology. Let's follow her as a medical staff. Long-standing low back pain. There is no anatomical pathology. Some MRI pathology, maybe degenerative changes. How we will approach, how we recognize, assess, and treat the patient. These two cases there before we go into the examination part. Finally, your assessment part. So summary is there. Poorly managed pain is a global health problem, and this course is essentially built to fill the gap, better understand and manage the patient. And there are few videos there. You should go through the EPM online course. It take 2.5 hours as a whole, but you can do it intermittently as your time convenient. Like this way you can spread the awareness among you and among the hospital, among the community. Okay, thank you.
That was a wonderful presentation.
Thank you, sir.
Now, any doubts from the participants? Dr. Samir, I want to ask one doubt.
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Yeah. So can we have in our railway on a regular basis? Is there any arrangements
Sir,
for that with any associations?
sir, your voice is breaking. You are asking. I think you are asking for regular assessment of pain. Naki, what is?
Pardon?
Sir, please.
Do we have any provision to connect with any association or national or state level or international to start some training programs within our railway hospitals?
Sir, for any start any pain any program, you have to be qualified enough. For any program you have to be qualified enough to start any program, first of all. Second, there should be infrastructure. There is clear cut guideline like FNB, like national board, to start any pain fellowships term 1 year or 2 year. There are clear cut guideline is there. Also from FIPM also allow to run course if they meet this criteria. So there are some criteria in India. There are some criteria. If some organization and some department meet this criteria, then they can start pain course.
Do we have enough number of case load in our railway setup?
Yes, sir, because pain is the major burden, and in our hospital, in every hospital, mostly orthopedician, mostly neurologist, neuropsychiatry, psychiatry, all these person are examining the patient, and they are giving some medication, and that's all. Also, some cancer patient from suffering from like first case, and the cancer female patient from gynecological problem. So actually patient from gynecology department, like chronic pancreatitis, actually patient from the surgical department. So when you start developing any pain program, then you will gradually got the referral. Then after it will establish your practice, then it will you got directly patient referral to you in your name. You will get directly got the referral, because pain is the sixth vital sign. It is the most important thing, and everyone wants to relieve their pain, and nobody know the pain better than the any pain physician. Because pain, there are different components there. Even Sometimes orthopedist doctor also prescribing some NSAID from long-standing low back pain. When there is no structural damage, we cannot use any NSAID for any chronic low back pain. There are some there are the neurotransmitter that is exhausted, like like serotonin exhausted, like noradrenaline is exhausted from the descending pathway. So we have to supplement this medicine like coanalgesic. So these are way we know the pain better than any other. So our field is growing on like this way, sir.
So how do we create awareness among our anesthesia colleagues that pain is also essential part of our curriculum and practice? And at
Sir,
the same
sir,
time, we need to create awareness among the patients also that this specialty is totally new one and it needs to be used,
sir,
well used for the better
sir,
relief.
sir, one of our senior doctor one day tells me that you have to use one pamphlet. You have to make one pamphlet ready, and one iCard is ready, and you should distribute rampantly whenever you go. What may be the conference, what may be the program, you should rampantly use your pamphlet and the visiting card to all, to aware them about the branch, about the specialty. Then only this specialty will grow. We have to take step individually to grow this field. Otherwise it will take a lot time to grow this specialty, sir.
Can you just briefly tell us about how many cases and what variety of cases you are doing at GR, Garden Reach Hospital?
Sir, from facial pain, from the migraine, like post-operative ear surgery, like trigeminal neuralgia, from gradually goes down to the neck pain. Neck pain may be some disc collapse, pain may be some facet origin, like spondylosis. Spondylosis, that means the facetal pain. So disc collapse and radicular pain is there, and spondylosis, non-radicular neck pain is there. Next come to the chest post of cancer patient presenting with the cancer CA lungs presenting with the chest pain. Post herpetitis neuralgia affected part the intercostal nerve distribution area, chest intercostal neural post herpetitis neuralgia pain. Next come you to the pancreatitis, chronic pancreatitis. Next come to the stomach gastric ulcer, gastric CA stomach related hepatic carcinoma, like uterine CA. Gradually you come to the genitourinary cancer patients. Then in osteosarcoma at the knee, at the lower limb, diabetic neuropathy. After minor trauma, he developed some like CRPS, chronic regional complex regional pain syndrome, like some Raynaud's phenomenon, yellow is bluing of the fingers, upper limb and the lower limb during. If we treat the Raynaud's phenomenon early, we may save his or her limb to get amputated. So there are lots of patient. I think pain medicine will be the field there. We will get referral, we will direct patient from the all specialty, because orthopedics doctor mostly treat not the fracture patient, only the pain patient. In their 80 case, 50 is the pain patient, low back pain, knee osteoarthritis, chronic knee osteoarthritis patient. We have the multiple option available, but them only one option, intra-articular steroid and higher Synvis and TKR. They have three options. We have lots of option available. We have PRP available, we have pooled radiofrequency ablation available, we have standard radiofrequency ablation available. We can do blindly, we can do fluoroscopic guidance, we can do sterile ultrasound guidance, but they can only do blind method. So we are more expertise in treating any pain condition than any orthopedics, any neurology. We got referral from the neuromedicine. Any low back pain not responding initial treatment, they refer to pain clinic. Sir, it is gradually develop. It takes time. You should start developing. I will request all the anesthesiologists to read about the pain, to read about the pharmacology, physiology, all things. Then only they understand there is a huge field. There are lots of opportunity.
Okay, thank you, Dr. Samir, for a wonderful elaborate lecture on the very important topic, and your subsequent discussion about how to go about to begin with the pain medicine practice and establish your pain practice, right from creating awareness among the public and other physicians by distribution of pamphlets, and as well as the distribution of our patient load, and how to initiate your efforts in a concentrated manner by just reading about pain and all the related subjects. I think it's a very good eye opener for many of our anesthesiologists, and I wish all the participants make much use of this session. And we look forward to have many more sessions from Dr. Samir regarding the practical aspects of different pain medicine techniques and procedures.
In railway, sir, just one thing to mention.
Yeah.
In railway, after that, after we started pain clinic and treated so many patients, I also got involved in some medical board case. So this is the negative part, what you may call it negative part, to start as a railway doctor, to by after treatment, or you also be responsible for the fitness, sick fit, this type of condition of the patient. Is he fit?
Actually, it is gaining
Uh,
more importance in the organization.
Yes, yes, yes. This type
So
of
the more
activity in this type of workload also be there after
yeah.
your initial treatment. Yes, sir.
So this should be taken as a positive result, because we are getting more recognition for our part of our services, and we
Yes,
will get more relevance in the system. So I feel
yes,
getting more involved in clinical practice through pain
yes,
medicine will enhance our utility in the department as a medical.
yes, sir.
All
It
of
will,
that.
it will improve because as a doctor, as an anesthesiologist, we are the integral part of ICU. We are the integral part of the inside operation theater. Also, we are the integral part of taking care of any patient suffering from pain. So our field is, I think, the most vast field in any organization, for any organization, sir.
I fully agree with you, Dr. Samir. And once again, I thank all the participants, and thank personally Dr. Samir Basak to devote his valuable time for us, enlightening us on the pain medicine. And we congratulate all the participants of his team, who has recently successfully conducted a wonderful 2 days conference and workshop, hands-on workshop on musculoskeletal ultrasound guided procedures and techniques. It was very well appreciated by participants, delegates from
Thank
mother
you, sir.
countries also. It was wonderfully
Yeah.
organized, and it was appreciated all over Indian Railways. Thank you.
Thank you, sir. Thank
Uh,
you, sir. Okay.
any Madam Dr. Kusuma is on with us now. Can I request Dr. Kusuma, Madam, to say a few words, Madam?
Uh, oh, actually, like we will, in a very small scale, we have started a pain clinic in our hospital from past 3 4 years, and here Dr. Balaji is Amrita Balaji is mainly involved in doing all the practical procedures. And I have one question for Dr. Samir. Like
Yes,
in
sir.
cancer pain, chronic cancer pain, what is this? Is there a ceiling dose for oral morphine?
Ma'am, in morphine, there is ceiling dose like more than 100 milligram per day. It will definitely cause respiratory depression. In our initial practice, madam, I have also witnessed one respiratory depression in a young, in a not a young, in a 45-year male patient, like 90 kg weight. I have prescribed OME, oral morphine equivalent. Madam, you should go through the OME. Always, when we use morphine, we also prescribe tramadol. We also previously prescribed buprenorphine. So we have to use the calculator to calculate OME, oral morphine equivalent. More than 100,
Oral morphine equivalent. Okay.
yes, yes, OME. We should use OME. If OME more than 120 milligram, then there is obvious chance of respiratory depression is there. So, ma'am,
Oh.
be judicious about using all the medication simultaneously, because it will definitely may cause respiratory depression at the middle of the night. Then we have to rush to intubate the patient, and after that we have saved the patient.
So this 120 milligram is for the younger patient, like a patient, a geriatric patient, the dose naturally will be
Those
even
will
less.
be
A C.
those will be less than 100 milligram daily,
I
OME.
see.
So, madam, morphine, oral morphine tablet is comes with 10 milligram only, not 5 milligram. but we should
Oh.
start initially at 5 milligram morphine, 4-hourly dose, and 6 dose minimum. So 5 multiplied 6 is 30 milligram daily is minimum. Starts with that OME dose, then gradually increase.
Okay. Thank you, Dr. Samir.
Thank you, ma'am.
In palliative medicine, they suggest if you exceed 60 milligram a day, then we should strongly consider using other adjuvant therapy or other multimodal approach. Because more than 60, the side effects will be really more disturbing for the patient, like constipation and pruritus and other things.
Yes, sir. Thank you, sir.
Any more doubts from the participants? Okay, if no more, nothing more to be discussed here, can we sign off this meeting today?
Thank you, sir. Thank you. Okay, sir.
Yeah, thank you. Thank you, Dr. Samir. Thank you, Kusma Madam. And thank you, dear participants. Thank you very much.
Thank you, sir.
Thank you.